We're going to talk about incontinence, and we're going to talk about urinary tract infections with kind of a perspective of how that might affect older individuals. All right, urinary incontinence, why does anybody care? We live in Michigan. That's why we care, okay? I interned in Florida, and there were a lot of people who leaked urine, and they didn't care. No, I'm serious. If you live in a state where it's 90 degrees, you're dry in 15 minutes. You wet yourself in Michigan, you're in for a long, ugly afternoon, okay? I'm really pretty serious about that. You know, when we talk about who do we treat for incontinence, it's like, well, who are we going to make better? You know, if you're bedridden, you know, your chances of being rendered dry if you're totally incontinent aren't very good. But if you have a life and a family and you enjoy activities, we want to get you dry. So we're looking for people who we can help and whose lives is going to matter. How we treat them is going to depend on their types of incontinence. So we're going to spend some time trying to identify the etiologies, okay? Now, everybody who lectures puts in this slide at least the first two things and then proceeds to ignore it, okay? The history and the physical. It really matters here, okay? If I do my job right, you're going to be able to diagnose probably 99 out of 100 people that come into your office with incontinence and do something to help them, okay? So this isn't a high-tech lecture, okay? It's not a complicated lecture, although you can certainly make it a lecture like that. You can talk about neural pathways and urodynamic studies, bore the crap at everybody and help no one. So if that's the esoteric lecture you want, I'm the wrong guy, okay? We're going for functional here. All right, there basically are 3 or 4 kinds of incontinence that you need to think about. There's urge incontinence, there is stress incontinence, there's overflow incontinence, and because you can break more than one thing, there's mixed incontinence. Okay? Now, forget all that. Okay? Stick with simple. Okay? And I'm going to try to make this really simple, and please do not be insulted by it. Okay? That's not my intent. My intent is to give you a way that is so simple that when you leave this room, you'll never forget it, you'll be able to explain it to your patients, and you'll be able to apply it. Okay? Being continent is a pretty straightforward process, but there's some things you need. Okay? And again, we're trying not to make this complicated, okay? The bladder is just a hollow bag of muscle. It's a balloon, okay? It's not a baggie, it's a balloon. It has the ability to stretch, and it has the ability to contract, okay? And once it's full, it can't get any more full, okay? So you've got a balloon, you've got a little straw, the urethra that drains that balloon, and you've got a pucker spring that's wrapped around the straw that crimps off the flow of urine. Okay? And the bottom line is your bladder needs to know when it's full, and it needs to know when it's empty. Okay? So you got to have a tank that has the ability to squeeze to empty. You got to have a pucker spring that stays tight when you don't want to wet yourself and relaxes and opens up when you do want to urinate. And you got to have a functional tube for it to come out of. Thank you, I'm done. No, that's really, no, honestly, God, and for that, you know, urologists aren't real smart, so it takes us 5 years to learn that, okay? But honestly, that's it, okay? Armed with that inane piece of information that I just told you that you already knew, we're going to diagnose the 4 major kinds of incontinence. We're going to tell you how to tell them apart and how to fix them. We're not going to go into surgery because you're not going to be doing surgery. If they need surgery, you'll send them to somebody else. But the other incontinences you will fix. All right, let's start with a common one. I'm sure you have a lot of pharmaceutical reps that come into your office and want to talk to you about urge incontinence. The new name for urge incontinence, the more common name, is overactive bladder, or OAB. Okay? Overactive bladder is not interstitial cystitis. It is not urgency frequency syndrome. We can fix that. That's a different topic. Okay? We're talking about urge incontinence. Cleverly named because you have urgency. Okay, I told you this was going to be simple, right? If you have urge incontinence, your major symptoms of urge incontinence symptoms Urgency, you got to go right now. You trample a cat getting to the bathroom. Okay? Frequency, you have to go often, and you probably have to get up and go at night. Okay? And if you get up and go to the bathroom at night more than about twice a night, you're not getting a whole lot of rest. Okay? And you just can't get to the pot in time. Hallmarks of urge incontinence. As opposed to stress incontinence. Okay? Stress incontinence is basically, well, let's go back. Urge incontinence is that your balloon has a bad attitude. Okay? When it starts to fill and stretch, it says enough of that. It responds by doing it. When you ask it to do its job, when you ask the bladder to stretch to store urine, it doesn't want any part of it. So as the bladder starts to stretch and fill with urge incontinence, it has little intermittent hiccups or contractions that gives you the urgency, and because it doesn't want to stretch, you get the frequency. Because it doesn't want to store urine, you get nocturia. Okay? That's a bladder with a bad attitude. That's urge incontinence. Is that painfully simple? Okay. Stress incontinence is a bad pucker spring. Okay? It's that little donut-shaped muscle that wraps around the urethra or the soda straw that drains your bladder. Okay? And to be able to urinate, you need to have a spring or a coaptation mechanism, if you prefer to sound like you know what we're talking about, that's snug enough that you don't leak urine, and yet on demand will open up so that your bladder empties. Okay? So generally with stress incontinence, the dam is weak. Okay? The sphincter can't hold back the volume in the bladder. It can't hold back the flood. And if it can't hold back the flood, you leak. Okay? So generally physical activity, stress type maneuvers, cough, sneeze, pick up something heavy, bend over quick, you lose urine. Now if you did an exam on these people, what you'd find is if you had a female in the lithotomy position with a full bladder, and she coughed or sneezed, they would probably jet urine at you. And you might see a stream of urine anywhere from a centimeter to a couple of feet shoot out at you. This is not to be done between the knees, okay? Stand to the side, look down. I've had residents that did not appreciate that, okay? So that would be a positive stress test, okay? I told you it's going to be hard stuff. Now, if you want to make this fancier, we refer to it as bladder neck mobility. What it means is that junction between the soda straw and the balloon, the vesicle neck, okay, isn't suspended high enough in the pelvis. It kind of has dropped down a little bit. The mechanism doesn't work, so when you call for sneeze, you lose urine. Okay? Are we okay with the way I'm explaining this? Because I can be really esoteric, but it just annoys me. Okay? This is more useful. All right, another really difficult concept to remember. Overflow incontinence. Okay? You're brushing your teeth, you close the drain, and the doorbell rings. You walk out of the bathroom. When you come back, the water is running over the sink. Okay? It's overflow. Why does it happen? Because you try to put more water in the sink than it will hold. Okay? That's what overflow incontinence is. Okay? Your bladder is so full, it can't stretch anymore, it can't hold anymore, and it's only got one way to exit at that point is overwhelm the sphincter, overwhelm the pucker spring by sheer pressure alone, and leak urine. Okay? That's overflow. Symptoms of overflow, if your bladder is continually full, then every 15 or 20 milliliters of additional urine that your kidneys produce has to go somewhere, but your bladder is full, so what happens? You go frequently. You lose urine on a regular basis. Every 15, 20 minutes, you're wet again. Overflowing the edge of the sink. Nocturia, you're full in the day, you're full at night. Urgency, yeah, your bladder's full. My goodness, you gotta go all the time. Your bladder's the size of the Goodyear blimp, right? And once again, if you think about this is why people get confused, but you need to understand the difference. If you have a full bladder in your pelvis, okay, and it's chucked just right up to the leaking level, and you lean forward, what happens? You push on the top of your bladder, just like stomping on a water balloon. It's got to go somewhere. It goes south. So that's why overflow incontinence can look a little strange. Okay? The concept post-void residual urine sounds really mystical or exciting. It's not. Okay? All it amounts to is you go to the bathroom and you urinate, and your bladder is supposed to empty. Post-void residual urine is that amount of urine that's left in your bladder after you go to the bathroom. It's that simple. Okay? Normal bladders hold between 350 and 550 milliliters of urine, and when they contract, they empty out down to just a few milliliters. Okay? Almost everybody's bladder that's healthy will leave less than 50 milliliters behind. If you get more than 200 milliliters behind after you void, you have a problem, almost certainly. All right? But remember, normal is you urinate and leave bladder sweat, as we used to refer to it. Okay, so overflow incontinence, how does it actually occur? Well, it's when the bladder is basically at full volume, the sink, and it can't stretch anymore. Remember, the bladder is a balloon, it can stretch, but at some point it can't stretch anymore, and the collagenous fibers in the bladder say, you can't stretch anymore. It's as if the bladder was made of hard material or had solid walls as opposed to stretchable walls. Causes the pressure inside the bladder to go up. And why would that happen? Well, it makes sense. What happens to men as they get older? The prostate gets bigger. It causes obstruction at the level of the prostatic fossa. It stands or crimps on the soda straw. It crimps off the outflow. And slowly over time, the bladder distends and the ability to completely empty is lost. Okay? So you see it in men with obstruction, most likely men that have prostatic problems, BPH, prostate cancer, or a problem more downstream, a narrow urethra from a stricture, okay? Or other person you're going to see this in is your diabetic patient who develops what is called diabetic cystopathy, which simply means their bladder doesn't contract. It doesn't have any oomph. And we don't have a whole lot of good drugs to make the bladder squeeze harder. We don't have, for those of us who are getting older, we don't have digitalis for your bladder, okay? There's not something, isoprel for the bladder. All right, mixed incontinence. And I think now you started kind of hopefully getting a sense as to what mixed incontinence would be. That might be an unstable bladder that doesn't want to stretch or contracts when it shouldn't, and perhaps some downstream either obstruction or downstream weakness of the sphincteric mechanism. That's how you can get sort of these hodgepodge of symptoms. Okay, all right? So mixed incontinence would either be obstruction downstream, a weak sphincter mechanism, or a bladder that doesn't want to empty very well. All right, so where do we go from that? Well, my contention is that simply by talking to your patient, you can probably figure out the difference of whether it's pure urge incontinence. They tell you they know they're going to go and they can't get to the bathroom fast enough, they go frequently, versus when they perform a Valsalvo activity, they increase their intra-abdominal pressures by a cough, a sneeze, lifting or bending. They increase the intra-abdominal pressure and urine comes out, stress incontinence. Overflow incontinence, they are chronically full, okay, and even just a very slight movement, like rolling over in bed, they lose urine, as opposed to a more vigorous activity like a cough or a sneeze, okay, versus some hodgepodge of that. So if we're going to evaluate them, well, things you want to make sure of, if you're going to have a urinary tract problem, get a urinalysis, okay? And it used to stagger to me the number of people that we would see in consultation in urology that didn't have a urinalysis. Okay, it's not that hard, it's pretty easy. We'll talk about how to get a specimen in a moment. But you're looking for things like blood in the urine, which may be the first and only warning sign of a cancer. Pyuria, pus in the urine. Sugar in the urine, very common to see with our diabetics. Proteinuria, more an indication of kidney disease. And cytology, I'm not in any way trying to imply that that's part of your initial workup. Cytology is the equivalent of a pap smear of the urine and is very dependent on how good your cytopathologist is. There are better ways to diagnose bladder cancer than a cytology. All right. If they have a questionable urinalysis, get a culture and sensitivity. Okay. One of the things that we would have trouble with in consultation is people would come in with a history of, I've been treated for 5 urinary tract infections, and yet they may never had a CNF done. What they really had was a bunch of dipsticks of the urine or some symptoms, but we never got a urinalysis and we never got a CNF. So if they have a urinary tract issue, get a urinalysis, and if you think it's infected, please get a CNS. Okay? Generally, the cutoff for red blood cells greater than 3, but that doesn't require $1 million workup. Okay? Post-void residual urine, depending how much fun you want to have in your office, if you have an ultrasound machine, you can have the patient, and here's how you can do a poor man's urodynamic study. Have the patient wait until they are full, they feel the need to urinate, they're at capacity. They go into the bathroom and they urinate. Okay? They urinate into a graduated something where you can measure the amount voided and record how long it takes. Okay? Now, so again, full bladder, go into the bathroom with a can and a stopwatch. They start to urinate when the urine starts. They stop the stopwatch when they're done. Now, that simple little maneuver, if you can urinate more than 10 milliliters a second, you're probably not obstructed. Okay, that's kind of a nice little cutoff. 10 milliliters per second, probably not obstructed. If you want to know if somebody has increased PPR, you can always just catheterize them or do an ultrasound of their bladder if you have that ability to see how much is in there. Or you can do something really radical and put your hands on the patient and see if their bladder's distended. I mean, I average a consult a month for an abdominal mass. That would be the bladder, up to the xiphoid. It's like, I'm sorry, your patient is not pregnant. They have a full bladder. Yes. The bladder can stretch to huge sizes if it does so slowly over time. Okay. Just please take it to heart. The treatment of incontinence is not a Foley catheter. Okay? It is appalling to think that we treat incontinence by just sticking a catheter in somebody and forgetting about it. And that's usually how they come to me. Somebody would be in the hospital, they would get an order for a Foley catheter, they'd get discharged to an extended care facility or a rehab unit or a nursing facility, and I'd see them 6 months later with a bladder stone or an infection or some other horrendioma. Indwelling catheters are a lousy long-term solution, and hopefully I'll be able to convince you of that in a moment. Bladder, a catheter has the potential to become encrusted with stones. Chronic irritation of the bladder can lead to a squamous cell carcinoma. And if you've got a Foley catheter, it's just a matter of when, not if, you get a urinary tract infection. Okay? That's simple. All right. Shift gears a little bit now. We've talked about the kinds of incontinence, post-void residual urines, symptomatically how to differentiate them. Catheters are miserable. Okay? So let's start talking a little bit about how to treat this stuff. All right. One of the things that drives researchers crazy is that if you do a study on a new medication for incontinence, for urge incontinence, 30% of people will get better if you give them a green M&M. Okay? Now, that's good for us, bad for the drug companies. Okay? It's good for us because simply talking to your patient about being incontinent makes them less incontinent. Okay? And there's some reasons for that. One of the best ways to reduce or avoid or prevent incontinence is with this. Time voiding. Okay? So if your bladder contracts when it shouldn't, when it hits 200 milliliters, then if you void before you get to 200 milliliters, you're not incontinent. Because people with urgent incontinence aren't obstructed, their bladders contract, they just contract when they shouldn't. And they may contract without any pre-warning. So they leak urine because of the severe urgency. They didn't get enough warning to get to the bathroom for a lot of reasons. Okay? So if you go before you've got to go, you won't be incontinent. That simple fact drives drug trials crazy. But it's something you can exploit without having any expense to your patient or medication side effects. Time voiding. Bladder irritants. Monsters. You know, the energy drinks. If you're sucking down 5 of those a day, you're going to have some urgency. Okay? You drink a pot of coffee before 9 in the morning, you're going to have some urgency. Okay? Which also takes us into if you reduce the fluids a little bit, the volume of fluid that you consume, you have less urine to have to deal with in your pants as the day goes on. Okay? So fluid reduction is another possibility. Pelvic exercises, and we'll come back to that. Weight loss. Again, if you have a massive amount of adipose tissue mashing on your bladder, okay, if you've got a beer belly and you bend forward, guess what happens? You pee yourself, okay? All of that extra adipose and intestinal tissue, if you will, mashes on your bladder and you lose urine. So weight loss will also make people drier. Pelvic muscles, exercises work. There are things that you can do. There are vaginal weights. There are vaginal cones. You can certainly improve somebody's stress incontinence if you can make their sphincter stronger, but you need to be committed to it. Okay? If you can't do it once this week and in a couple of weeks get back to it, it requires regular routine exercise, and most people don't have the commitment to do that. Okay? You've all heard of Kegel exercises, right? Okay. It is the most, if you want to have a good laugh sometimes, check out how they tell people to do Kegel exercises, okay? Because I would never be able to figure out how to do a Kegel exercise. I mean, one of my favorites was, imagine that you have a quarter between the cheeks of your buttocks and walk around like that all day. I cannot imagine that, okay? So, here's the easiest way to think of a Kegel exercise, that you can explain it to anybody. We're not born knowing about our sphincters, right? So here's the way to think of it. If you've all had children, if anybody's got kids, everybody has found themselves in the bathroom trying to urinate, and suddenly the family needs to talk to you, okay? And as you're urinating, the parade starts, and you need to cut the stream off midstream, okay? That interruption of a stream is a Kegel, guys, okay? So if you want to practice Kegels, for men, you walk into the bathroom, you start to urinate, and as you're urinating, you do whatever it is you do to cut that pucker spring off. However you think of that happening, that's what you do. And the idea is you practice squeezing it, relaxing, squeezing, and relaxing. And when you get bored with that, then you squeeze it and hold it to the count of 3. When you get bored of that, squeeze it, hold it to the count of 10. When you get really good when the commercial comes on TV, you sit on the couch and you're squeezing and practicing. And eventually what you're going to do is you're going to take this voluntary muscle and convince it that it should stay contracted voluntarily. It's that simple. And if you can do that, if you can make that, now, or you can have several $1,000s of bills in biofeedback and walk around the 10 unit like a thing in your pocket, or you can just practice in the bathroom when you get bored. Okay? That's a Kegel. All right, urge incontinence. Only if you really don't like people, okay? The first time I gave a patient oxybutynin or ditropan, I still remembered I put him on this, and I got a call in the middle of the night, and I thought it was an obscene phone call. There was this kind of guttural mumbling going on. It was my patient, and their tongue was stuck to the roof of their mouth. And I never forgot that about good old-fashioned ditropan, which was 5 milligrams PO 3 times a day. We have gotten better. We now have extended release ditropan. We have transdermal preparations. which have gotten vastly better. And for some people, they may need a medication like oxybutynin. Most patients who have urge incontinence do not need a medication that is sort of, well, you know, they're anticholinergic, antimuscarinics, and the problem is they have a lot of side effects with them. And one of the side effects is a dry mouth. Well, that was really helpful, Doc. Thanks a lot. Okay? That's just, you know, this like giving poison ivy to somebody who complains of an itch. You know, it's just rude. We have newer, and the only thing that's probably worse, in my opinion, than the oxybutynin with probanzoline, which generally you're only going to use people with serious cord injuries, neurologic injuries. But you have a whole lot of other choices. Detrol LA, Sanctura, Vesicare. And the thing is, just because one of these doesn't work, doesn't mean that the other one won't. So if somebody comes in and says, I tried, pick your choice, Vesicare, and it didn't work, you may find that switching them to Detrol does. Okay? They have similar side effect profiles, but they are all different enough in their action. One may work and another not. Now, one that I have a particular affection for is the Nabalex, and it's because it doesn't cross the blood-brain barrier, and it's less likely to cause sedating cognitive dysfunction in older people. There's actually a great study out there where they basically gave people ditropan and then tested their IQs and their cognitive abilities, and they all fall like 10 to 15 points. Okay? So it's like instant stupid. Okay? So when your patients come in and say, I took that drug and I couldn't find my keys, yeah, you did it to them. Okay? So that's why a sort of a selective M3 blocker was helpful. This is why Enablex became as popular as it was. And if you don't like that one, wait a week, there'll be something else. All right. Now this is a little off the beaten path, okay? Things that have also been used for stress incontinence, tofranil or remembermine, the drug that we use in kids for nocturnal enuresis, primary nocturnal enuresis, bedwetting, not FDA approved, but what it does is it actually has some effects to make the bladder relax as well as tighten up your pucker spring. So it has kind of a double action there. And unfortunately, like many drugs, if you ask why it works, I haven't got the vaguest idea, nor does anybody else. Okay, but it is something you can keep in the back of your mind that makes you look smarter than the average person. All right, so stress incontinence, weight loss, pelvic muscle exercises, quit smoking, and the behavioral changes that we addressed. Again, stress incontinence, FDA. All right, we good with urge incontinence? Basically, we're talking about medications that make the bladder calm down a little bit. Get rid of that bad attitude that we talked about.
What's the measure B? There's a new one they keep pushing on us.
Oh, the one the lady takes her bladder for a walk, the Geriatric. Yeah, thanks. Yeah.
How does that work different than the other ones?
Different flavors. Yeah. And part of that, all of these drugs, if you ever listen to the little blurb at the end, it says, if you have, call your doctor if you develop a weak stream, okay? Because what's happening is they're anticholinergic. And if you relax the bladder too much, then you can't generate any oomph. Okay? Actually, I should have put in that drink. My wife loves that little bladder. I'm enamored with it. Okay, overflow incontinence. Okay? Again, back to the analogy of the sink. You're continuing to make urine. It's continuing to go into the bladder, but the bladder is already full. Okay? It never gets the ability to rest because it can't empty. So that 500 milliliter bladder contracts, but maybe only gets rid of 200 or 300 milliliters of urine, has a high post-void residual urine. Poor bladder contractility. In the old days, there was a drug called methanyl chloride, also called Duvoid, one of the great names in urology. Never worked terribly well. I prescribed tons of it. It doesn't really fix the problem. It's kind of like whipping a dead horse.
Does it do more neurological dysfunction as well? A lot of my patients that have had strokes, that's one of the major issues.
Well, yeah, and see, the problem with a stroke, it depends where it hits you.
Right,
Because to be continent, you have to know you're full, and then you have to be able to trigger your bladder to empty when it wants and keep the sphincter tight in the interim.
yeah, because even sometimes they have the broca, so they can't communicate, but they can say, yes or no. I say, can you feel that you have to urinate?
And some can't. Some can't feel when they're full. A lot of diabetics, I used to see this in a lot of diabetic men, they can't tell they're urinating.
No,
They get, they come, their pants are wet. What happens? Like, oh, I didn't know I was done. I just kind of tucked it away, and suddenly I was wet. It's like, well, there's a solution to that. Look down before you.
yeah.
I mean, sometimes the solution isn't hard, and other times it's,
It probably is a neurological thing too, along with the diabetes, of course.
Absolutely.
Yeah.
That was brilliant. Remember, the diabetes not only affects the ability of the bladder to squeeze, it also affects the sensory components, so you don't know what's going on in your bladder. And because the bladder can adapt so well, has the ability to get up to your xiphoid over time, that's like a couple of liters.
Yeah.
Okay, I mean, my personal best was a gallon that I took out of a guy.
Yeah.
But if it happens slowly enough, the body will tolerate a lot of evil.
Oh, that's for UTI, because you have residual.
Oh, absolutely. You can have a zoo growing in there and they don't even know it. Okay, so if your bladder can't squeeze, how can you empty it? Don't say catheter, please. Kind of a catheter. Intermittent clean catheterization. This ad is all over the TV. There's a lot of money to be made in it because you don't actually fix the problem, you just sell them the device. Okay? So basically, it's a catheter, and when you feel full, or a certain amount of time has elapsed, or you have consumed a certain quantity of urine, you catheterize yourself. Okay? Now, I'm not going to kid you. Nobody ever woke up in the morning and went, "Woohoo! I get to catheterize myself." And I've never met a man yet who when I said, "You need to stick this tube in your penis 4 times a day," he said, "Well, that's a fine idea, Doc. I'm really looking forward to that." Okay. It's just, no. But what I will tell you is, like most things in life, after you do it for a while, you find out that it's, I don't like it. You're not supposed to like it. You're supposed to drain your bladder, okay? And it works because it's a way to empty the bladder, and basically that overflow incontinence is gone, okay? And it's just kind of a quick story. My wife's a triathlete, and on the website there was a young woman who had posted that she didn't know how she could continue competing. She was a world-class athlete. She was totally incontinent after pelvic surgery, and they put a Foley catheter in her and told her that was going to be her life. Okay? Now, I mean, it's ridiculous. So this woman would never be able to bike again, swim, or run, or compete as an elite athlete. And the solution was, they blew out her nerves during surgery. They injured her. Okay? I can't comment as whether it was good, bad, or different. I wasn't there. But what I do know is her bladder doesn't contract. And the solution is simple. Catheterize yourself. Pop that puppy in there, drain your bladder out, take the tube out, chuck that thing in the garbage, and get on with your life. It's that simple. Okay? You don't have to ruin your life for something that's that simple. And for some reason, I can tell you why. Intermittent catheterization is not sexy, and it doesn't make urologists any money. Okay? And you can't operate on it. You think they're interested in taking care of it? I'll let that up to you. But what is important, though, is you can fix somebody's problem in a primary care office, or at least suggest it. Yes, ma'am.
We can remodel the heart, get the muscle to work better, so that the patient is bladder is muscular issue, and we can retrain the bladder.
There actually is a procedure where you can do a plication of the bladder, where you split it down the middle and kind of fold the edges over each other and double the thickness. Doesn't work real well. There also are actually bladder pacemakers, where you can, it's just what it sounds like. You have a little external device that you can trigger that tells the bladder to contract. The problem is with bladders is once they get really distended, they sort of lose their ability to contract. Whether you shrink them down in size, it just doesn't work real well. We've tried a lot of things. There are bladder pacemakers, but usually I've not had a lot of great success with it. And we don't really have a good pharmacologic way to make the bladder squeeze. Duvoid was about it. We have done other strategies where we said, well, if we can't make the bladder squeeze harder, can we make the sphincter relax more so that there's less downstream resistance to overcome when the bladder does contract? Problem is then you wet yourself.
The bladder is smooth muscle, and the other muscles that you can apply medication to are striated or the cardiac muscle. So
This is even weirder than that. I used to do an operation called an ilioneobladder for bladder cancer. What I would basically do is take out a man's prostate and bladder, do a radical cystoprostatectomy, and then I would take 70 centimeters of small intestine and kind of wiggle it around and make a bladder out of it. Sew my new bag bladder down to the urethral stump, plug the ureters into it, and these people thought they could pee normally, and they did. By being able to valsalva, they could empty this bag I'd make for them. The bladder would start to act like a bladder. It would fill and hold with urine, and they'd get the sense of needing to void. Okay? This is that part where I said I'm going to lie to you a little. I'm going to make this really simple. There's a lot more going on here than we can talk about here. Okay? So bladders just don't behave like hearts is the problem. I wish they did. Okay, so there's kind of, does all of that make sense? So stress incontinence, what can you do in primary care? You can try to teach them something to increase the tone of their external sphincter. You can actually, there are non-medication uses. We talked about the imipramine. They're also used to, anybody remember Drixoral? Twice a day, big green pill. God, I love that drug. I fixed more men with radical prostatectomies that came to me for second opinions for incontinence. It had a really ugly side effect of acute urinary retention. But if you gave it to a guy that had a radical prostatectomy, it tightened up their sphincter enough where they were now dry. Okay? And then they took it off the market and my guy got wet again. But you can give somebody an alpha agonist, tighten up their pucker spring, or teach them Kegels, you can make them dry. Or you can have them void, timed voiding. You hear nothing else, timed voiding. Thank you, I'm done again. That catheterization for overflow, timed voiding for urge incontinence, that will make a tremendous difference in probably half of your patients with incontinence.
Well, the problem too, like, when you're talking about things about the bladder or even drinking, I have some patients that stop drinking at 5 in the afternoon. Now they get kidney dysfunction because they're so dry.
Yes. Yeah. And unfortunately, there are doctors who tell them that, restrict your fluid, which there is a downside to that.
Yeah.
Which is always why it's nice to be able to get a different option for them. Now, there are other, if you want to talk more about incontinence, we can. I mean, there are artificial urinary sphincters that basically are, imagine a 1 centimeter sphygmometer. Instead of the cuff being 12 centimeters, it's 1 centimeter. Okay, and instead of wrapping it around your bicep, you wrap it around the urethra. It's a surgical procedure. Okay, and when you want to urinate, the little cuff mechanism is wrapped around the urethra. The on-off switch, if you will, the reservoir pump mechanism, we hide in the scrotum or in the labia. And then when you want to urinate, you squeeze the little release bulb. It deflates the fluid in the cuff. The urethra opens up and you void until the cuff automatically reinflates itself. Okay? I'm smiling because I have a gentleman where I put one of these things in and tried to explain to him how to use it. He called me one night and I said, you got to just fuck it up. You just got to squeeze harder. The pump. And he came in the next day, Doc, you got to take this thing out of it. Well, what he was doing, he was squeezing his epididymis. And I felt, tell him, my God, I'm telling this guy squeeze harder. But clearly, there are some things you can't discuss on the phone, and and we talked about the bladder pacemakers that are out there. Generally, not all that helpful to most people. Plication of the bladder. If you had a bladder that was really, really teeny, like a neurogenic small capacity bladder, you can actually split open the top of the bladder like a clamshell, and then take a piece of small intestine, do your magic, and make a patch for the top of the bladder and increase the bladder capacity that way. a bladder augmentation. The other things that you can do, there are different ways to drain the urine. If somebody absolutely needs a catheter, consider doing a trocar cystotomy, a long-term trocar cystotomy, where instead of the tube going through the perineum or up the urethra, it comes out above the pubic bone, much easier to care for in terms of keeping it away from the fecal stream. It doesn't rub you raw in the middle. I'm sure most of you have seen the problem with catheter drag, where if the catheter is on tension, even a little bit of tension long term, it will actually bivalve or split the penis. And I've actually seen the penis fissure from the meatus all the way back to the scrotum, just due to chronic drag and pull over time. So catheters are not benign creatures. Well, it's very good with the comment. Poor choice of words, yes, sir. Absolutely. Yes, in fact, in Lansing, there was actually a group of nurses that was kind of their bailiwick. Yeah, the problem is trying to find somebody that wants to do it. Some physical therapists who have a particular interest in it, absolutely, can biofeedback. Another, it works, provided your patient will work it. Unfortunately, this is America, where I want a pill. I want it to be gone by noon, and I want it to be free. So trying to get somebody to do it is a little tougher sometimes.
I said physical therapist. We're talking osteopath.
Absolutely.
Have you had much experience with
Have I personally? No.
No. Listening to the patients.
Yes. And here's not to anybody's surprise, the more motivated they are, the better it works. And part of the problem is teasing out that 30% that would have gotten better with the green M&M. Okay? But in terms of osteopathic treatments, people are using sural nerve stimulators that work. So again, some of this gets really exotic and interesting, some of the feedback loops, but it's way beyond what we're doing today. Yes, absolutely it works.
Those stimulators make for good KGS. I did a graph clearance on a lady, and the girls are like, these knees are broken, something's wrong. We had her come back in the afternoon with DPG. Finally figured it out.
What it was?
Yeah. Just made her based on her.
That's great. I've not heard that before. Yes, sir.
I have a question, a little different. It has to do with the urine analysis that you were talking about earlier. When you're looking at the urine analysis and trying to make a decision as to what's going on with the patient, I've noticed that a lot of times, even though I ask the patient and but explain to them how to do a midstream catch, I get an awful lot of abnormalities.
Would you wait?
Go ahead.
No, you're like 4 slides ahead of me.
Oh, okay.
But thank you. And he was not paid to do that. Okay, but that's a great segue. That's exactly where we're going next. That's kind of why these two topics got stuck together. Anything else for the moment? Anybody know what time it is? Oh, I'm sorry, guys. I run my mouth too much again. This is what I did last year. How about if we kind of just do some of the highlights on the UTI? You want to do that, or you want to just say I screwed up again this year? The highlights. Bugs for fun and profit. Cost us a lot of money. They're real common. For that, I needed 6 slides. All right. Different things to think about. In the urine, there is contamination. Okay? Guys, as men, when we get a urine specimen, we really do not have the appreciation of what we're asking for our female patients. Okay? Can't see their urethra. Some of them can't even see their stream. If they have a mild cystocele or a prolapse, their stream may not even vaguely go in the neighborhood it's supposed to go targeting-wise. Okay? If they're obese, they're trying to sit on the toilet with parts kind of falling in on each other. Okay? Trying to get a clean catch midstream in a woman, if it ever is clean, is a minor miracle. So seeing contamination in a clean catch midstream urinalysis in a woman requires some gymnastics on a good day. If you really want to get a midstream clean catch on a woman, the simplest way to do, and it's humiliating and almost nobody can do it, is wait till your bladder's full, put them in the lithotomy position, and then say urinate. Because we all are used to doing that, laying there and whizzing off into the lithotomy position in space. But you can actually get one and open up the labia so that you're not doing a ricochet shot with the stream off of the labia or the thigh. This is so difficult. I've actually had one lady brought me with your urine specimen, and I held it up to the light, and I realized there was toilet paper in it. Okay, in her attempt to get my midstream, she dipped the cup in the toilet. Okay, and then said, no, this is probably going to be contaminated. So we just threw that one out. We'll try again on another day. So contamination, stuff that was never in the bladder, joined the party, jumped in your cup. Okay? Colonization, this is a big deal. Very common in elderly people. Because they have an altered immune system or a defunctionalized bladder, germs get up into their bladder, have a party, and they're not able to urinate them out because their bladder doesn't contract well enough. Okay? But it causes asymptomatic bacteria. These people may have no symptoms. They do have bugs in the urine. It's a real phenomenon. There are bacteria in their urine. The hallmark is it's not causing the patient any trouble. And that's why we may not need to treat those people. Okay? There's more to a urinary tract infection than simply the lab saying we did a dipstick and found bugs on the urinalysis. Okay? On that, I'm sorry?
Will a diabetic feel that?
They may not. No, and the other problem is kids. I mean, kids with a urinary tract infection, particularly prior to being able to talk, their only symptom may be a little irritability. Or, they don't want to eat their favorite food. I mean, they can have strikingly minimal symptoms. The kid I would treat, the elderly person, I probably would not that was colonized. But, yeah, I mean, not everybody feels this stuff. Absolutely. Now, there's 100 ways to get schnookered here. Absolutely. Okay? So, that's our colonization. Infection, and this is really the deal. You gotta have symptoms, you gotta have bugs, okay? And your symptoms are generally caused because the bug is annoying your bladder, okay? It's causing an inflammatory response inside the bladder. The bladder now looks like you took a Brillo pad to the inside of the mouth, okay? A roaring urinary tract infection, okay? Part of the reason you get hematuria from a urinary tract infection, the infection causes such profound erythema in the wall of the bladder that blood leaches through the bladder wall and shows up in your urinalysis. What happens is, after you really annoy the bladder wall and put them on antibiotics, the bacteria may be gone, but the inflammatory process persists. So if you dipstick their urine after you've treated their infection a week later, you may still see blood and even inflammatory cells because even though the germs are gone, the process persists. Does that make sense? Okay. Recurrent UTIs, again, it is possible to have a UTI, clear it, and it's gone, and then have a new germ or have an infection again in the future. The definition of recurrent UTI is 2 or more infections in 6 months, or 3 or more infections in a year. Documented infections. I want to see urinalysis and culture and sensitivities because I want to know, is it the same bug that came back? Is it a different bug? And did the sensitivity change? Okay? Because there's a difference. Versus reinfection, where it may be a completely different germ than the one they had before. Versus this ugly little booger. Persistent UTIs, which generally means they're hiding somewhere. Okay? Might be an infected kidney stone, might be a bladder diverticulum. We're not eradicating the bug.
See a lot of those in the nursing home.
Absolutely.
See a lot of those in the nursing home.
Absolutely. Yep. I'm going to skip this. I'm going to get to the urinalysis, collection methods. Okay. Clean catch midstream, catheterized, or stick a needle in the suprapubic region if you really want to make sure you're getting real bugs. I don't want to do this. Okay. This is your slide. I lied, it's more than 6. If you're looking for ways to know if it really is an infection, leukocyte esterase is produced in the presence of infection. So if you have leukocyte esterase on a dipstick urinalysis, you probably have an infection, as opposed to something like a yeast infection or a ricochet shot off the labia while you're trying to get your midstream. So the caveat, leukocyte esterase, the presence of nitrates in the urine, and again, WBCs or pyuria. Now, if you see things that just don't make sense, you're like yeast and pyuria, you're probably looking at contamination. It's far more likely that it's contamination of the specimen than it is a candidal infection of the bladder in a diabetic. Did that answer?
What about RBCs? See that one?
How many?
More than what they say is allowable.
Okay, well, remember, if they have an infection, RBCs are expected. Not going to be surprised. If you have an infection and you treat the infection, you can have RBCs in there for six weeks to 3 months and still be a normal finding.
With just a routine urine analysis. See, that's it.
When do you get excited about blood in the urine?
Yeah.
That's the question? All right, I'm going to try to give you the best answer I can tell you. If you're 20 years old, the chances of you having a bladder cancer are close to squat. Okay? If you're a 50-year-old man who smokes and you got blood, ding, 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 you just got yourself a workup. Okay? So there's not a magic cutoff for blood in the urine that says, worry about this, don't. They actually tried to do this study 40 years ago. And they kind of thought that maybe 10 RBCs per high power field was suggestive of a correctable urologic problem. Well, that's useless, because that included things like urethral strictures and BPH and bladder cancer, which arguably are not exactly the same thing. So there is not a magic cutoff for the amount of blood. What I will say is it needs to be explained, okay? And the problem we have with men in hematuria, they can get up in the morning, urinate out tomato juice, the next void is clear, and by dinner time, it never happened, okay? Men are idiots, okay? They will tolerate, come on guys, okay? We'll minimize anything. Gross hematuria that spontaneously clears gets ignored by the vast majority of patients. And I don't think I ever did a radical cystectomy for bladder cancer on a patient that did not have gross hematuria within the year prior to my taking their bladder out, okay? Now, the difference to that is, though, you want to get a guy into your office at light speed, let them see a drop of blood in their ejaculate.
Yeah.
Okay? Man, that scares them like there is no tomorrow. Blood in the urine, not so much. Okay, I'm over. I apologize. I'm going to go away. But thank you for your attention.